Good evening, all. Welcome all of you for our GP's Cafe for July month. Till our CPD coordinator joins, I'll start the meeting. This is the meeting that we have a special occasion because this is the 6th anniversary we celebrated yesterday for GP Cafe, and Dr. Sanka is there, one of our uh, pioneer member and one of a eminent member of Wonka, and he has been YDM lead of Wonka once, and Gobit is there. Gobit is been there as the YDM lead in Sri Lanka in GP Cafe. So we want to hear from Sanka first about the history and what has happened for these 6 years. Sanka, can you please explain in 5 minutes time?
Thank you very much, Asita. Hi, everyone. Good evening. Asita requested me to do a very brief description about initially the spice route. Actually, the spice route movement is the Sri Lankan arm of Wonka Young Doctors movement of South Asia. Wonka has 7 regions, and each region has Young Doctors movement. Wonka, as you know, Wonka is World Organization of Family Doctors, and each region, out of the 7 regions, each region has a Young Doctors movement, and the South Asian Young Doctors movement is known as the Spice Route, and the Spice Route Sri Lanka is the Sri Lankan arm of that Young Doctors movement, and the Spice Route movement in Sri Lanka was established in 2016. When actually it was in parallel to the Wonka South Asia Region Conference happened in Sri Lanka in 2016. And if I go to, before that, if you want to know more about the Young Doctors movement and the Spice Route, you can go to the Wonka website and look into the Young Doctors movement and get to know about the activities and how you can join, etc. And I'm sure that our members will also, the office will also let them know how to do that. So then about this GP's Cafe, which was started almost exactly 6 years back, on 19th of July 2019, was a result of a discussion then in the National Committee of the Spice Route Movement Sri Lanka. I was the chair of the Spice Route Sri Lanka, and we wanted to have some sort of a CPD activity which doesn't need farmer support for 2 reasons. One, it was difficult to find farmer support always, and the second reason was we didn't want to have that farmer influence much. If you go back and see about this six years before, how the world was 6 years ago, how we were operating 6 years ago, most of the continuous professional development programs were physical, face to face. Very rarely we had online stuff. I mean, it has become totally totally different by now, and there's a total change. But if you really go back and think, can you remember how many of online sessions were there? So this was that period, 2019, just before the pandemic, in July. So we decided we are going to do something innovative. Yet it was a bold decision because we were not sure how would be the response to this. So we initially got together and met in the college council room, in the College of General Practitioners of Sri Lanka council room. We had a notice, and we told, okay, we have a limited number of seats. So it was a physical meeting initially, which was well attended, and we discussed very casually, in a sort of, not in a very formal manner, in a casual way. We discussed family doctors, issues, cases, interesting cases. So this happened exactly 6 years ago, and it was very well received, more than what we thought of. And the main idea was something like a place where people get together. Just say a cafeteria, just like the kopi kade in Game. So where people can get together and discuss something in casual way. So that's the way, that is the initiation of this GP's Cafe. And we had a few GP's Cafe sessions again and again. And even before the pandemic started, we started to live stream this, because there was a lot of sort of different people were asking us, inquiring us whether they can join that, because the number of seats were very limited. So we started even live streaming via Google Hangouts then, where the Zoom was unknown or unheard of or less heard of. And so it was going forward, and we met with the pandemic, and we slowly converted this into an online session. So after 6 years, I'm very proud to say that our colleagues are carrying it forward strongly in better ways. And now each and every month we see GP's Cafe, and sometimes physical GP's cafes as well in the conferences. So I think we have shown some sort of an example. We have set an example which has gone as a model forum for the continuous professional development, as well as where you can do some innovation and adaptation according to the time. So I'm very happy about today. And so I wish you all the best, our team, Spice Route, for going forward strongly. Thank you.
Thank you, Sanka. And now it's been a place where we offer CPD points, so you can be a very proud pioneering or leading founding member of that. Thank you for your kind words and the introduction of what happened. Kobit, please share some idea in 2 minutes, please, because you have
Yeah,
been a
yes, thank you for the opportunity. Yes, I'll make it quickly. Yeah, I'm also a very happy person to be here all these 6 years in from the inception, and even though more from even 2016. So yes, as Sangha said, yeah, we were searching for the one of the mode of deliver the some of sort of discussion, case discussion, or maybe connect with our the GPs and our young doctors. So this is the what we have seen. You can see even for the who are joined recently also, you can see our how our GP cafe is going on. Even we are discussing our day-to-day cases in a very different way. So we are discussing. So we are sharing uh, our point of view, and so finally we get some sort of that our updating knowledge. Yes, as you said, your from the beginning we started about as a the physical one. Then I remember from the second day, second month, so I started Hangout. How I handled that, actually, I was the background of this Hangout. So there's a huge number of requests to attend in the virtual things. So we finally found something in the Google. So maybe nowadays the Hangout has changed the name even. So even though before the Zoom era, so I'm very happy actually. And also now we got even CPD points. So I'm seeing, so always the amount, they say that 100 people are joining in the limit, so we are going to increase even the unlimited very soon. So I'm so wish all the people who are this involved in the GP Cafe in other all the development. So thank you all so for joining. So you will continue. Thank you.
thank you, Kobit. Thank you, Sanka. And kudos to everyone who started this wonderful movement and the arena for platform for young doctors to share their ideas, their suggestions, their innovations, and also their experience. So there are a lot of people behind this movement and the GP Cafe. So I make this opportunity to thank them for having this, starting this. And Gobit and Sankar, thank you very much for being very good advisors to us. And we are very proud of you too. And we are very proud that you have become Wonka members and you are going forward as young doctors always. And that's actually inspiration as well as a blessing to us. So I invite our CPD coordinator, Dr. Praneeth Nishad. He has joined. Good evening, Praneeth.
Good evening.
The screen is yours. You can introduce our speaker and go forward.
Okay, thank you, Asita. Happy birthday to everyone on 6th birthday of our GP Cafe. Today, we are very happy because our Spice Rose movement has evolved in such a way that many people can join and have a good time updating their knowledge. And today, because of some technical issues, I could not join in the first 2 minutes, 3 minutes. Sorry for that. And so Dr. Sank and Gobit and the team who carried this way, we thank them all. And shall we start then without going more in time? So our speaker today is Dr. Manoj Liyanage. He's a MBBS holder from University of Sri Jawadanapura from in the year of 2015, and he's a dedicated family physician with postgraduate qualifications in family medicine such as DFM, MCGP, and MRCGP International. And he is currently serving as a registrar in family medicine at the PGIM. And in addition to his clinical and academic work, he's a certified lifestyle medicine physician, reflecting his commitment to holistic evidence-based care. And he also contributes to actively for the professional development of young doctors, as in this session, as the editor of Spice Route Sri Lanka Council and secretary of the Spice Route Movement South Asia. So over to you, Dr. Manoj, to continue and have a nice time with our CPT session.
Good evening, everyone, and thank you, Dr. Praneeth, for the introduction. And I thank National Committee of the Spice Route for giving me the opportunity to present in the today's GP's Cafe. Today, I'll take you through a real-life case about a silent metabolic condition that challenged routine care and eventually became a turning point. We'll explore risk, resistance, and finally the recovery, all from a GP's perspective. So my patient is Mr. P. He's a 51-year-old businessman. He came for a routine checkup before an overseas trip in 6 weeks. He didn't have any symptoms, and he showed me some investigation reports. These are reports. His fasting blood sugar and HbA1c were normal, but take a look at his lipid profile. It's alarming. His total cholesterol is 480, LDL is 288, and triglycerides are extremely high. It's 2736, and HDL is low. So, from the audience, what are your thoughts when you see this triglyceride level?
Familial hypercholesterolemia.
Yeah, that's a possibility. You can use the chat box even.
Maybe the report error.
Yeah.
Fast in duration.
It's a fasting sample. That's also a very important point we have to check.
Most probably a false report.
Yeah, that can be a false report also. Yeah. When I saw this report, I had the same queries. And I went to the history. So let's now revisit the patient's background in more detail. Patient is Mr. P, 51-year-old businessman. He came for a travel-related checkup and had no complaints at all. He has hypertension and hyperlipidemia, but no other major conditions like diabetes, thyroid, renal, or inflammatory disease. There's no history of pancreatitis, and he was on bisoprolol, telmisartan, and rosuvastatin, but he's not been compliant, and there were no known allergies. And he had no family history of lipid disorders, diabetes, or heart disease. He's a businessman and had good family support. However, he had a 15 pack year smoking history and drinks heavily, about 15 to 20 standard drinks daily, with signs of dependence. He had tried quitting before but failed. He led a sedentary lifestyle and denied taking a high fat or high calorie diet. And psychologically, he was under stress, mainly from work and family responsibilities. His main coping method was alcohol, with some passive strategies like watching TV. And functionally, he was fully independent in daily activities, actively working, and had no issues with cognition or mobility. So, as a family physician, what are the other aspects we must explore in the history?
Drug compliance.
Yes. Compliant, I mentioned, he didn't have good compliance.
Family history of cardiac, young age of cardiac death. I mean, in the father, mother.
His family history is not significant. I mentioned here, no family history of lipid disorders, diabetes, or any cardiovascular disease. Yeah. So I the patient's hidden agendas. So from the patient's perspective, he wasn't sure if alcohol was truly the cause of his triglycerides, and viewed that reducing his intake had already helped. He was anxious about being admitted to a public hospital with these reports and worried about costs in the private sector. He also feared this could delay his travel to see his daughter and newborn granddaughter. He expected a home-based solution that wouldn't disrupt his life of plans. So moving to the examination, he was afebrile, not pale or jaundice. There were no lipid-related signs like corneal-lacus, xanthelasma, or xanthomas. There were no signs of chronic alcohol use such as parotid enlargement, palm erythema, spider nevi, or muscle wasting. He had no signs of dehydration or edema. And his BMI was normal, it's 21, and his vitals were stable with slightly elevated blood pressure, 140 or 80. And his neurological examination also normal, and abdominal examination was also normal. There was no hepatomegaly or evidence of pancreatitis. So this is the report. This was the report I got, and I repeated the lipid profile, and it's the same result. So given these findings alongside with his history and examination, what concerns do you have? What are the other investigations you need?
ALT,
Yes.
ultrasound scan of the abdomen and liver.
Yes, very good. ECG. Actually, when he came to me first, he got all the reports with him. So that made my life easier. So his full blood count showed normal white cells and hemoglobin platelets, but his MCV was elevated, suggesting macrocytosis. And his thyroid function was normal, TSH. Earlier enzymes were markedly raised. SGOT 120, SGPT 19, those are not that raised, but his gamma GT is very high at 2964. ALP and bilirubin were normal. And serum proteins coagulation studies are also normal with normal serum amylase. And so in this context, what does this liver profile suggest in with regard to his alcohol use and lipid profile?
Early liver parenchymal disease could be the reason, right?
Yeah. Can you think of the driver for that? Main reason for the liver derangement?
Excessive alcohol consumption.
Yeah, very good. What are the clues
History.
in the history examination and mainly in investigations?
Raised gamma GT.
Yes, very good.
In the history, you said that he is a alcohol user and he is a heavy alcohol user, right?
Yeah.
So
And MCV
Yes, very
is
good.
high.
He had macrocytosis. Usually in the liver, when we talk about liver enzymes in alcoholic patients, usually the SGOT is twice the value of SGPT, but not in this case. But if there is that SGOT to SGPT ratio is 2 to 1, it's strongly suggestive of alcohol use and the gamma GT with normal ALP. So I'm moving to the rest of the investigations. His kidney function was normal and electrolytes were mostly normal with slightly low potassium levels. His urine findings were also unremarkable. ECG showed no abnormalities. Some scan, it revealed grade 2 fatty liver, but no signs of pancreatitis. With these results, what are your thoughts? So my working diagnosis was very severe hypertriglyceridemia associated with alcohol use disorder. Would you consider any other possible diagnosis or any contributing factors? So going with my diagnosis, I thought of assessing his more. His alcohol use history showed long-term regular drinking, mostly in evenings. And he had been drinking strong lager, about two 625 milliliter bottles daily, totaling roughly 77 units per week, which is well above safe limits. He had tried quitting before, but was unsuccessful, with stress and social events as triggers. Screening scores support possible alcohol dependence. His scale scores 2 and the audit scores 15, indicating hazardous to harmful use. Using DSM-5 criteria, he meets moderate severity for alcohol use disorder. He had no history of seizures, delirium, and tremors, so withdrawal risk was low, making community detoxification feasible. Psychosocially, he was in the contemplation stage, motivated by family, especially he wants to visit his newborn granddaughter. He had concerns about hospital cost and fear of failing as well. Physically, he didn't have any signs of liver disease or withdrawal symptoms at the presentation, and he didn't have evidence of pancreatitis. But very high triglycerides remain at risk still. Would you consider managing him by yourself or admit him? What are your thoughts? Patient with confirmed hypertriglyceridemia with triglycerides more than 2000 with high gamma GT levels.
They have good family support. We can manage at home with good.
Yeah, we have assessed him now. So I thought of the same because the patient refused hospital admission and specialist referral even. So my initial plan was to it was focused on lifestyle changes, that is strict dietary fat restriction and removing added sugars. I advised him to continue rosuvastatin and his antihypertensives bisoprolol and telmisartan, bisoprolol small dose 2.5. And a quit plan for alcohol use was also initiated. This is that. He was at the contemplation stage, aware of his harmful alcohol use and had tried quitting before. I delivered a brief introduction, which I'm going to discuss later, linking his alcohol use to high triglycerides and explaining risks like pancreatitis and cardiovascular disease. We explored his values and readiness, addressing barriers with a motivational and judgmental approach. Together, we could set a agreed quit date. With that, for the pharmacological support, thiamine was prescribed to prevent Wernicke's encephalopathy. I prescribed thiamine 100 milligram 3 times a day. I did that at the first presentation. And chlordiazepoxide was given in a fixed dose tapering regime for withdrawal management. Safety net included involving his caregiver as his wife, confirming low withdrawal risk in the assessment, and daily follow-up to monitor symptoms and self-monitoring of blood glucose and blood pressure. He had the facilities. So during the first week, he was reviewed daily for withdrawal symptoms. I monitored his symptoms, vital signs, medication adherence, and tolerance. I also checked on his diet and alcohol reduction progress, screened for any withdrawal symptoms and side effects, and reinforced motivation with lifestyle advice and coping strategies. Daily support and brief counseling were the key components. And we discussed he had 15 packets of smoking, and he was in the contemplation stage for smoking cessation. He recognized the harm and had reduced the number of cigarettes, but was not yet ready to quit completely. So I focused on harm reduction and I encouraged self-monitoring to reduce the number of cigarettes and plan to revisit the quitting in future visits. Since his quit date, he had maintained abstinence from alcohol and reports better energy and sleep after 1 week. There had been no withdrawal complications. He was sticking to a low-fat, no added sugar diet with strong caregiver support from his wife and regular follow-ups. Overall, his well-being has improved and he remained engaged with the care plan. After 1 week, the patient stayed abstinent with only mild withdrawal symptoms, which I managed well, and his blood pressure and blood sugar remained controlled. He adhered well to self-monitoring and blood glucose and blood pressure self-monitoring supported his wife. Importantly, his triglycerides dropped from 2736 to 1008, and gamma GT decreased from 2964 to 2025. So after 1 week, further drugs were added. For alcohol use disorder, I started topiramate 25 milligrams twice daily to support abstinence, and to manage severe hypertriglyceridemia, I added fenofibrate 67 milligram capsule, that's micronized form, daily, and omega-3 fatty acids 2 grams daily also added. As a lifestyle medicine physician, I incorporate lifestyle medicine principles in managing all my patients. So I would like to highlight 6 pillars of lifestyle medicine here. There are key areas where lifestyle changes can significantly improve health outcomes, especially in metabolic and cardiovascular diseases. They include nutrition, physical activity, stress management, sleep, avoidance of risky substances, and social connection. Now I'll show how I integrate these 6 pillars into managing my patient by combining tailored nutrition advice with encouraging physical activity, managing stress with mindfulness exercises, ensuring good sleep, and supporting cessation of harmful substances, mainly the alcohol, and reducing smoking, and strengthening family support from his wife. I aimed for a holistic approach which improves outcomes. And after 3 weeks, the patient continued abstaining from alcohol and made significant improvements in diet and lifestyle. His triglycerides continued to trend downward. He reported better sleep and more energy. Regular follow-up was maintained, and he expressed hope and confidence in long-term recovery. These are the values after 3 weeks that showed clear improvement. Total cholesterol dropped to 352, HDL improved to 57, LDL reduced to 221, triglycerides decreased dramatically to 369. Liver enzymes also improved, SGOT 62.2, SGPT 70, and gamma GT down to 1203. At 6 weeks, he maintained abstinence and showed marked improvement in his lipid profile, especially triglycerides. His weight was stable and his mood had improved significantly. Family support remained strong, and at that time, topiramate was discontinued, and rosuvastatin and fenofibrate were continued. And he successfully traveled to Australia to visit his newborn granddaughter. And these are the reports after 6 weeks. His latest lipid profile showed excellent improvement. Total cholesterol was down to 187, HDL was healthy at 54, LDL raised to 115, and triglycerides normalized to 91 from 2900. Liver enzymes significantly, GOT 69, SGPT 28, gamma GT is still elevated but much lower at 230. So this case shows how primary care can effectively manage complex metabolic issues. Despite initial resistance with tailored lifestyle advice, pharmacotherapy, and ongoing support, and especially with proper safety netting, recovery was achieved. I had the privilege to present this case study at WONCA South Asia Region Family Medicine Conference in 2025, held in Bangalore. So next, I'll cover some important theory in clinical reasoning. Because of time limits, I'll go through these slides quickly for us to have a discussion. I focus mainly on the key points, and I will post the slides in GP's Café's WhatsApp group so that we can continue discussion there. So when we talk about hypertriglyceridemia, it is classified by fasting triglyceride levels. Normal values under 150, moderate 150 to 499, moderate to severe 500 to 999, and severe more than 100 over. Clinically, it's often silent until values are very high. Signs include eruptive xanthomas, abdominal pain, or pancreatitis, especially with very high triglyceride levels. And from the fundoscope, we can see lipemia retinalis, and sometimes hepatosplenomegaly and flushing with alcohol. There can be short-term memory issues in severe cases. It's called this collection of these symptoms and signs are called chylomicronemia syndrome. There are primary or hereditary causes of hypertriglyceridemia, which is familial, and there are secondary causes. which include metabolic and endocrine disorders like obesity, metabolic syndrome, diabetes, kidney disease, and hypothyroidism. Lifestyle factors such as high calorie diets, sugary drinks, and alcohol, I mentioned, also contribute. Pregnancy, especially in the third trimester, can raise triglycerides. Other causes include systemic conditions, which is multiple myeloma and lupus. Many medications can also raise triglycerides. Important ones are thiazides, diuretics, and non-selective beta blockers, glucocorticoids, and hormonal agents like estrogens. We have to go through the patient's drug history when we encounter patients with high triglyceride levels. So when we discuss about management of hypertriglyceridemia, management starts with thorough initial assessment. First, we have to rule out or address secondary causes like I mentioned previously. And we also have to screen for signs of acute pancreatitis and assess cardiovascular risk factors. Non-drug measures are always essential, and we have to advise very low fat diets. It's less than 15% of daily calories from fat. In this patient, I tried even less than 5%, while restricting simple carbs and sugars. Complete alcohol evidence is critical, and for overweight patients, calorie restriction and weight loss should be strongly encouraged. Physical activity should be moderate aerobic exercise for at least 150 minutes per week, usual aerobic exercise. For severe hypertriglyceridemia, fibrates like fenofibrate are first-line drugs, and it can reduce triglycerides by 30 to 50%, though they take a few weeks to work. Gemfibrozil should be used cautiously with statins due to myopathy risk. And omega-3 fatty acids at prescription doses, like 2 to 4 grams daily. Usually, some patients takes that it's less than 1,000 milligrams. That high doses of omega-3 can lower triglyceride by 20 to 45%. And we usually add it as an add-on therapy. Statins may reduce cardiovascular risk and lower triglycerides moderately by about 10 to 30%, especially when triglycerides below 500. They are not first line for severe hypertriglyceridemia, but important if cardiovascular risk is high. And niacin can lower triglycerides and raise HDL, but it's less preferred due to side effects. Severe hypertriglyceridemia, risk of pancreatitis or having pancreatitis, we can use insulin therapy in especially tertiary care settings. This is a nice to know thing I included. And there's another option plus. After starting treatment, we have to recheck fasting triglycerides within 2 to 4 weeks. Patients with very severe triglyceride, and also we have to monitor lipid profile, liver and kidney function, and blood sugar regularly. It's important to watch for pancreatitis symptoms and check adherence to lifestyle changes. Long-term goals are to prevent pancreatitis by keeping triglyceride below 500, ideally under 200, and reduce cardiovascular risk by targeting non-HDL cholesterol under 130 according to guidelines, or under 100 in high-risk patients. Treating secondary causes and educating patients helps to prevent recurrence. This is how alcohol increases triglycerides. Alcohol raises triglycerides through multiple mechanisms. It increases liver fat production or the hepatic lipogenesis. It impairs the body's ability to clear lipids. and it mobilizes free fatty acids from fat stores. It worsens insulin resistance, and it causes higher fat levels in the blood after meals, known as postprandial lipemia. So now I'm going to talk about alcohol use disorder. It's a chronic relapsing brain disorder marked by compulsive drinking, loss of control, and negative emotions when not drinking. I'm going to introduce three terms here. Hazardous drinking means a pattern that raises risk of harm, and harmful drinking it causes direct health problems. Alcohol dependence involves craving, tolerance, and continued use despite harm. Alcohol use disorder consists both harmful drinking and alcohol dependence. This is the DSM-5 criteria. It defines alcohol use disorder using 11 criteria. Diagnosis requires at least 2 criteria to be met within 12-month period. Due to time, I'm not going to go through the slide. You can have it. This flowchart outlines the recommended approach for outpatient screening and follow-up of patients with alcohol use disorder. I got this from American Academy of Family Physicians, and it highlights how primary care can play a key role in early detection, intervention, and ongoing support. I won't go into every step here, but the key takeaway is the importance of structured and consistent follow-up and individualized care paths. In primary care, alcohol screening should be routine, not some reserved only for obvious. We can integrate it into everyday practice, such as when registering new patients, reviewing medications, managing chronic illnesses like diabetes and hypertension. It's also an important consideration in settings like antenatal care, sexual health consultations, or even during visits for minor injuries, because alcohol use can influence so many aspects of health. The key is normalization the conversation, making it a standard part of comprehensive care. To assess drinking levels properly, as in bacteria for smoking, we use the concept of units of alcohol. 1 unit equals 10 milliliters or 8 grams of pure ethanol. The formula is simple: volume of drink in milliliters multiplied by alcohol content divided by 1000. So in my patient, he consumed 1,250 milliliters of alcohol daily, 2 bottles, with ABV 8.8%. So he consumed 11 units per day, which comes to 77 units per week, far above safe limits. And screening tools confirmed the concern. I used Cage score 2, which indicates positive screen for problem drinking, and his audit scores 15 points to hazardous or harmful drinking, which requires structured intervention. This is a Cage questionnaire, a quick and widely used screening tool for alcohol use. It includes 4 simple yes or no questions. Each yes equals 1 point. A score of 2 or more suggests problem drinking and possible alcohol dependence and indicates the need for further assessment. In my patient's case, the score is 2, so I raised concern and prompted deeper evaluation. The audit is a comprehensive screening tool developed by WHO to identify harmful alcohol use and potential dependence. This is Audit C, a short 3-question version focused on alcohol consumption. It's quick to administer and good initial screen. This is another version, Audit PC, that's for primary care. It has the first 3 are the same for Audit C, and additional 2 questions are there. Addition to those 5 questions, this is full audit. It includes another 5 questions. So altogether 10 questions, which gives a broader picture covering consumption, dependence, alcohol-related harm. In my patient, full body scores 15 in harmful drinking that which needs structured intervention. So the audit questionnaire helps to classify the severity of alcohol use. This is another questionnaire, SADQ, or severity of alcohol dependence questionnaire, which is self-administered. It's a more detailed tool used to assess the severity of alcohol dependence rather than just the presence of risk use. It consists of 20 items in 5 subscales, which explores physical and psychological symptoms, withdrawal symptoms, alcohol consumption, and things. So this questionnaire helps to guide our treatment plan and especially decisions around detoxification and withdrawal support. So in primary care, managing alcohol use disorder involves several steps. We have to start with a structured brief advice session on reducing alcohol consumption. If that's not enough, we can offer an extended brief intervention for harmful drinkers or those with mild dependence. Psychological interventions can be very effective. Prophylactic oral thiamine is important to prevent complications like wernicke's encephalopathy. And we should provide clear information and advice tailored to the patient's situation. We should arrange regular follow-ups to support ongoing progress and adjust the plan as needed. This approach allows us to manage alcohol use disorder effectively in the community without always needing specialist referral. This is structured brief advice. It follows PRAME's principles. The PRAME's principles guide us how we deliver structured brief advice effectively. And this slide 5S and 5Rs approach. The 5S and 5Rs are structured frameworks used in brief interventions to support behavior change. The 5S guide assessment and action steps. That is ask, advise, assess, assist, and arrange. The 5Rs focus on motivating patients by discussing relevance, risk, rewards, roadblocks, and repetition. This is the trans-theoretical model of behavior change that describes how people change behavior in stages. Namely, pre-contemplation, that is not yet considering change, contemplation, thinking about change, preparation, planning to change soon, action, actively making changes, and maintenance, sustaining new behavior. Sometimes relapse can occur, and the cycle may repeat. Understanding these stages helps to tailor interventions to where the patient is in their readiness to change. When we manage patients with alcohol use disorder, patient, we have to think about the contraindications, which includes history of withdrawal, delirium, or seizures, and moderate to severe withdrawal symptoms, complex medical comorbidities, unfavorable psychosocial factors, and pregnancy. These conditions require inpatient or specialist care for safe management. And this slide shows a community detoxification contract. I took that from Australian Journal of General Practice. It's an agreement between the GP and the patient to ensure mutual understanding. In current legal context, we have to think of this as well. And this slide outlines the chlordiazepoxide fixed dose tapering regime for alcohol withdrawal management. I took this from UK guidelines, and we other benzodiazepines that can be used include diazepam and lorazepam. And in this patient with high deranged liver enzymes, I would prefer lorazepam, but it's not commonly available. The drug should be chosen based on the patient factors like liver function, withdrawal severity. In some cases, carbamazepine and phenobarbital also can be used, but it's not commonly used. We can use if the benzodiazepines are contraindicated. This slide shows the DSM-5 diagnostic criteria for alcohol withdrawal. I won't go through each point due to time, but it's important to recognize these criteria for timely diagnosis and appropriate management of withdrawal symptoms in clinical practice. This slide shows the typical timeline for withdrawal symptoms, symptom onset after stopping alcohol. Symptoms usually begin within hours and peak around 24 to 72 hours and can last up to a week or more. Knowing this timeline helps us to monitor patients closely during the critical withdrawal period to prevent complications. And this is a screening tool to assess the severity of alcohol withdrawal. And before we move on, I would like to ask the audience a quick question. Do you prescribe medications for alcohol use disorder in patients who are not yet ready or willing to quit drinking?
No.
No, no.
No, normally we ask from the patient and get the consent, and then we have to start it with the consent, and we discuss with the family members, especially wife. So then the initially the drinker should have like to that to adhere it. Otherwise, no point of giving alcohol at all. Yeah.
Yeah. Actually, what I meant was, can we prescribe drugs for patients who are still taking alcohol to reduce drinking with the patient's consent? Are there any drugs which can be used to reduce drinking?
Yes,
Naltrexone.
chlordiazepam peroxide.
So naltrexone, I think naltrexone is the best drug for the alcohol dependence. It has a effect on the alcohol compared to other drugs.
Yeah.
But the case is naltrexone is a very expensive drug. So
Yes, now it's cheaper. I think it's not now. It's become less 380 rupees now per day. It's cost going down. It's initially was 1,000, now 650, now
yeah,
380. Yeah.
yeah.
Compared to
Yeah.
alcohol, because they are drinking a lot.
Definitely.
Yeah.
Exactly. So
About the chlordiazepam peroxide.
in withdrawal, alcohol withdrawal, we can use chlordiazepam as to reduce withdrawal symptoms, but the recommendations are different. This slide summarizes the AFP recommendations on medications for alcohol use disorder. Here, patients who have alcohol use disorder should be offered pharmacotherapy with evidence rating A. Medications like naltrexone, acamprosate, and topiramate can support patients at different stages of readiness to change. They can help reduce cravings, prevent relapse, and support abstinence, but should be a part of comprehensive care plan, including counseling and monitoring. So, if a patient asked about a drug to reduce his craving, with the alcohol, we can use these drugs. Usually in Sri Lanka, what we practice is after with alcohol, complete abstinence from alcohol, we start these medications.
So, what about the how long we had used for naltrexone?
It depends on the factors. That's why I mentioned we have to review them daily. From my experience as naltrexone in clinic, they use for about 6 months, sometimes even longer.
Yeah. Right.
This advice us on selecting the most appropriate medication for alcohol use disorder based on patient factors, preferences, and clinical considerations. It helps to tailor treatment to maximize effectiveness and safety in primary care settings. I won't go through every step, but it's a useful tool to support shared decision making with patients.
Manoj, probably you can tell something about the popular drug dalsalfiram.
Yeah, I'm going to talk about the medications as well. These are the summary of medications. Naltrexone we can use to reduce heavy drinking days or remain abstinent. The usual dose is 50 milligram per day, and we can start with 25 milligrams and increase up to 100 milligrams if the patient tolerates. And there's an intramuscular preparation as well, but it's not available in Sri Lanka. It is given monthly. And the literature says the use of gabapentin, but they are talking about the doses like 3,600. I'm not sure whether our patients can tolerate that much of gabapentin. They are unable to tolerate 100 milligrams even. And we can use acamprosate to remain abstinent. And this is about topiramate. It can be used to reduce heavy drinking days. Initial dose is 25 milligrams, increase 25 to 50 milligram every week to maximum dose of 300 milligram per day. And baclofen is also used, and varenicline. Patients with tobacco use disorder and who is also has alcohol disorder, we can consider about the varenicline. And this is regarding disulfiram. We can use that to remain abstinent when supervised for adherence. That means when we prescribe disulfiram for a patient who's on alcohol, it can give rise to serious consequences. So sometimes patient, especially the relatives, ask some tablet to take to prevent their relative from taking alcohol without their consent. If we prescribe something like disulfiram, it can be fatal even. So this case reminds us that meaningful change can happen even when a patient initially resists. With patients, support, and tailored care, recovery is achievable. It highlights the crucial role in primary care in guiding patients from resistance to recovery. And I used family medicine principles in practice, namely patient-centered care, continuity of care, comprehensive care. And I incorporated holistic approach with collaborative decision making. These principles are key to effective primary care management and improving patient outcomes. This case, the turning point is more than just a clinical case. It's a reminder that silent conditions like severe hypertriglyceridemia can have serious consequences if missed. Patients always follow our initial plans, but with patience and support, change is possible. In primary care, we don't just treat lab values or diseases. We guide whole lives. Remember, sometimes the greatest breakthroughs in medicine don't happen in hospitals. They happen in quiet consultation rooms where trust, persistence, and continuity meet. With that, I'll conclude my presentation. Thank you all for your attention and participation today. I hope this case and discussion have been helpful for your practice.
Right. Hey,
Yeah. Thank you. Thank you very much.
Thank you, Dr. Manoj Liyanage, for your excellent presentation. We have also turned point. It's enhanced our knowledge as well as enlightened the audience. I suppose Dr. Asita will hand over the certificate for the CPD points.
Can you all see this?
Thank you, Dr. Asita.
Yeah, the people who have joined also can get the CPD points through our college. Please join our GP Cafe's Spice Route WhatsApp group. So please contact the college if any concerns. And so we'll be concluding this session. Shall we ask any other questions the audience has? Because so many people have contributed actively throughout the session. And if any other questions, they can post now.
I have one question to Manoj.
Yes.
That was a very nice presentation, Manoj. Thank you very much
Thank
for
you.
preparing that. That was a really good one. And I don't have such patience. Did this patient really come daily for review and for this 6 weeks, because he had intention
No,
to
I didn't review him daily for 6 weeks. It was only for the first week. After that,
first week.
after 1 week, I reviewed in 3 weeks, and then after 6 weeks.
Did he come in 1 week, the first week daily? Was
Yeah,
he such good
he came
motivation?
daily.
Because he had to go to visit his
The
granddaughter.
intention clearly stating that he has to come to the practice daily.
Good. Thank you, Manoj.
We are coming to the end of the session, and because of the 6th birthday of our Spice Route. Anyway, I wanted to thank Dr. Sankar, Govit, and the team at the beginning. I could not do it because of the technical error. Anyway, because Sankar, Govit, and people have started their journey, and we are continuing it with the help of Dr. Asita and the team. Manoj is also contributing. Dr. Priyanti, Chatura, our team is very friendly and so harmonious to proceed. So we'll be continuing another 1 year as the 1K YGM in Sri Lanka. And I wanted to thank again Dr. Manoj for his excellent presentation. Because he's a pioneering person in our young team. So anyway, sorry for your I could not join in the beginning. So we'll be finishing it. Good night for everyone.
Good night.
Good night. Thank you, Praneeth, for your valuable support.
Oh, Rokshanaya, thank you. Okay, bye.
Bye. Bye.